Today we shall discuss the case of a JNA patient who had undergone pre-operative embolization and internal carotid artery sacrifice. So this is a pre-operative CT. This is the case of a young boy who was having repeated epistaxis. So these red arrows point towards the large mass in the right infratemporal fossa extending into the sphenoid sinus, into the orbit, and involving the red cavernous sinus bulging into the middle cranial fossa as well. This is the bone window. We can clearly see the Holman-Miller sign, which is a classical sign associated with JNS, where the antral wall is pushed forward. We can see remodeling of the bones of the skull base. We can clearly see whitening of the foramen here, so that the mass is bulging inside the orbit. We can see the mass here. It has remodeled the sphenoid wall as well. There is no destruction of the wall, though it's just remodeling and expansion. A contrast MR is seen. You can clearly see the hyper enhancing extent of the mass. It's a pretty large mass with a quite significant lateral component. The intra-orbital component is very well seen. We can nicely see the paracellular component. We can see this is the flow wide of the right internal carotid artery, and the mass is around this, about between 180 to 270. I would say it's not completely encircling, but the neurosurgery and ENT team were a bit reluctant to completely excise this tumor. So they asked for a preoperative TSA and embolization of this case. This is the right internal carotid artery injection. This is the frontal view. We can see nice visualization of the intracranial circulation, and we can see the mass filling quite significantly from the internal carotid artery as well. The lateral demonstrates the finding much better. We can see feeders directly from the internal carotid artery as well as from the ophthalmic area. So this is the tumor blush from the IC run. This is the external carotid artery injection. We can see large part of the tumor being supplied for the external carotid artery. This is the ascending pharyngeal, and this is the internal maxillary artery. We did a cross flow evaluation, so we can see the ACOM is nice. There is very good perfusion of the right hemisphere across the ACOM. There is also a PCOM, posterior communicating artery. So the patient had very good circle of Willis support of the right hemisphere, and perineal sacrifice was an option for this case as well. So we went ahead with the embolization. So this is a microcatheter injection of the distal right internal maxillary artery. We can see large part of the tumor is filling with this. This was embolized. This is a selective run of a right ascending pharyngeal artery injection. We can see small part of the tumor being perfused here. That was embolized. Notice the posterior division of the ascending pharyngeal is intact. This is a ascending palatine, a branch of the facial artery. There was some supply from this. This was also embolized. So 3 pedicles from the distal IMA, all embolized with PVA particles. And this is the post ECA embolization common carotid artery run. We can see complete disappearance of the blush from the ECA component. After embolization for the ECA, this is the injection from the right internal carotid artery. We can see the blush which was seen has decreased, possibly due to percolation of the PVA through collaterals, but there is some art filling still visualized. This is the mandibulovidian, and at this point now the option were that we just leave it, or we do a percutaneous embolization of the component near the internal carotid, that is the intracranial component, or we do a parent vessel sacrifice. Patient had already been counseled for parent vessel sacrifice. It is not a very common procedure to be done. However, in some situations, if the surgeons feel like they can take it out, means they can take out the tumor completely, this is an option, especially if there is very robust cross flow. Now, most situations, the surgeons are happy to leave these tumors in there, and there are other options, including medications and stereotactic radiotherapy to take care of the intracranial component. However, in this case, it was thought that the tumor can be completely excised, and considering that there was good cross flow, we will do a parent vessel sacrifice of the internal carotid as well. There is an option of placing a balloon in the internal carotid and doing a onyx injection percutaneously. However, I don't do that. Even if there is 1% or 2% complication, I don't accept it. And onyx embolization occasionally, even with balloon, can lead to issues, and I'm not very keen to have complications in my hand in these elective patients. So this patient underwent sacrifice of the internal carotid artery. This is the post sacrifice. You can see the flame like lower part of the internal carotid. There is nothing going inside, so it's completely sacrificed. Just the coils are lying just till the origin of the ophthalmic artery. These are the final runs. This is the RCCA post-embolization injection, showing the complete disappearance of the blush of the tumor. We can only see the external carotid artery branches, and just the tiniest stem of the ICA is seen below till this point. This is a left common carotid artery mid-phase injection. In the anteroposterior view, we can see very good perfusion of the right hemisphere across the ACON, almost at the same time without any significant delay compared to the left. Sorry. This is the CT scan post-operative. Tumor has been completely excised. There was no complication, no infarcts, no bleed. This is a contrast scan, and the patient did well. So to summarize, this is a case of a JNA with intracranial extension. IC sacrifice and preoperative tumor embolization was done. The embolization of only the external carotid arteries was done. Tumor was completely excised. Parent vessel occlusion for JNA is not a very well established technique. Can be useful in some cases. It is a bit controversial as well. Young age of the patient helps in good outcomes, but there is always ethical dilemma because of the same reason. However, we have followed this case now for about 3 years, and patient is fine. The long-term outcome